Deuk, CEO and founder of the Deuk Spine Institute, here with my team at the Deuk Spine and Surgery Center Vieira, getting ready to perform our last surgery of the day, 6 cc's. Our patient has 2 herniated discs, one at L4-5, the other at L5-S1. She's traveled to us here in Orlando, near Orlando, Florida, actually the Space Coast, just outside of Orlando, from Alabama. She's had pain for a long time, years, and tired of being in pain. All right, so we're going to get started. The first disc we're going to go after is the L5-S1 shot. Of the 2 discs, I think the L5-S1 is worse than the L4-5 in terms of the appearance on the MRI. I don't know which one is going to be more painful for her, shot, but we're going to find out very soon. Perfect. I'm right up against the facet. Shot. Are you okay? How's her blood pressure? Shot. Wonderful. All right. She's awake and reliable. Shot. Right at the back of 5-1. Let's get an AP view. She doing all right? Any back pain? Huh. Interesting. It's a little more lateral than I want to be. Let's go back to the lateral view. Can you, I think we're off on WAG just a little bit, like the tiniest bit. I wonder if we can improve that a little bit. No. Other way, maybe. No, it's too much. Well, just go back to where you were. You're about 1.5 degrees off. I think we could do a little bit better than that. Shot. I don't know. I think that's worse. What do you think, Luis? Let's just see. I think we're dealing with like a parallax issue. Let's go back to where you were. Shot. That's good enough. I think we're going to have to be happy with that. There's probably a little bit of scoliosis. That may be why. Shot. Shot. Are you awake?
Yes, don't move your head. Yep.
Don't move. Just lay still, okay? It's very important you lay still. All right, release the WAG. I'm going to try to get this a little better.
WAG is released.
Shot. I wonder if it's an orbital issue we're dealing with. I don't know. It's hard to tell. Lock it right there. Because 5-1 is not that collapsed, yet it looks collapsed in the back. Try playing with the orbit just a little bit. Maybe 1 degree. Let's see what happens. That's worse. That's as good as we're going to get at 5. All right. I'm not unhappy with that. Let's just leave that. I think I need to be a little more superior. Shot. Shot. Are you okay? Shot. Yeah. Shot. So that's what it was. That's a little better. Shot. You having any pain? All right. Shot. Must be hitting the sacrum. Shot? Uh-huh. Let's see. Stay where you are. Blood pressure is good, yep. That's interesting. Let's get a AP, see where we are. All right, so our patient has two herniated discs. One is more degenerated, that's the L5-S1, that looks good. And then the L4-5 is a better preserved disc, the injury is not as old. And we're trying to gain access to the bottom disc through the foramen right now. Are you okay? Yeah. All right. Shot. The approach that I'm using is very similar to the approach that would be taken for an epidural steroid injection shot. A transforaminal shot. Epidural steroid injection. Shot. I feel like I'm right on her herniated disc. And yet, I'm unable to pass through. Shot. Am I just rubbing against the end plate there? It's kind of what it looks like, huh? Looks like I'm right on the S1 end plate. Oh, let's try again. A little bit higher. Shot. Shot. So when I say shot, what I'm asking for is a picture, an x-ray picture from my team. There we go. That worked. All right. Are you comfortable? No leg pain? Good. All right, let's give her a little more numbing medicine. This is for Dr. Berndes to put a smile on his face. Now we're using the x-ray machine to navigate from the outside world here into the herniation. And you use the x-ray because it's the best medical imaging system available to do this. We could use ultrasound, but it wouldn't work. We could use MRI, but it wouldn't work. CAT scan, but it's way unnecessary to use that much radiation. So the very best tool is called the intraoperative fluoroscopy. It's used by both neurosurgeons and orthopedic surgeons that do spine surgery and joint surgery. It lets us see joints and soft tissues between the joints. How are you feeling? You're doing really good, by the way. I'm going to be able to put you to sleep soon. Okay, we're right on the next herniation. Any pain in your leg? All right. Big tear there, I could feel it. All right. Are you comfy? Okay, so at this point we've done, I think, the hardest part of the surgery, which is to get into the disc safely. And we're really going to be fixing two discs, the L4-5. L stands for lumbar, 4-5 is the 4 bone and the 5 bone. And this is the disc between the number 4 and 5. And then the L5-S1, which is really the bottom disc in the spine. So you really have 5 discs in your lumbar spine. These are the bottom 2. Now the most common disc in the world to get injured and cause pain is L4-5. And just right behind that guy is L5-S1. L5-S1 is the second most common disc to cause problems. Now she has a tear in the wall of the disc. That tear has allowed the herniation of the jelly to come through. She's had her pain for years. All right. Now, are you comfy? Any pain at all? All right. We're going to put you to sleep soon. I know you're a nurse. I have a lot of nurses in my family. Okay. How bad is that on a scale of 1 to 10?
Yeah, it's a
10? Is that where you typically get your back pain? I got some great news for you. When you're done with this Deuk laser disc repair, that pain will be gone forever. Isn't that great?
Awesome.
Does it feel better now?
It's where it's gonna
Okay, I apologize. We had to test to make sure we're fixing the right disc, okay?
Okay.
And you passed the first one. So we know, folks, that this first disc right here, I just tested it. You can see a big tear in the back. Jordan, you want to show our viewers the tear? Can you see the white arrow there, Henry?
Yes, we can see it.
Show them the tear. The arrow is running over the tear. That's actually the needle. But the tear is from the arrow all the way back there, yeah, and you can see the dye leaking out. And again, we just saw one of these in the last case where the tear was on the bottom side of the annulus. This again is on the bottom side of the annulus. Is that better?
Yeah.
All right. How bad is that?
About
Give me a number.
8.
8. Is that where you typically get pain?
Yes.
All right. 8 over 10. So I want you to count out loud for me from 1 to 100 in Swahili. Can you do that?
No, sir.
All right. How about English?
2.
Good.
Please, you can switch.
Shot. Keep going. Shot. You're doing good. So we're going to start with 4, 5. Okay, now this disc is different. You can see that most of the dye is sitting in the middle, but there's some globular areas, and what that's showing you is that that's not normal. We're seeing damage to the inside of the disc, and the dye is kind of going into these globular areas, indicating there's scar tissue forming partitions or walls. And you can even see a small tear in the back. You want to go to that lateral view and show them that curvilinear tear coming out the back of the disc right there? No, the back of the disc. It looks like, yeah, it looks like a saber. It's kind of curved. So that's an annular tear at L4-5. I have a feeling we're going to see quite a bit of internal disc disruption on this one. Shot? Almost there. Now, for those of you wondering, where is the nerve root in all of this? Why don't you show them where the nerve root is, Jordan? Just above the dilator in that window above the... Go ahead and take another picture. Yeah, you're correct. That's it. Can you guys see that, Henry? Where the arrow is? Circle it.
Yep.
The nerve root comes out right where his arrow is. So we're just underneath the nerve root, the exiting nerve root. And that's why I have the patient awake in the beginning to make sure I'm not poking through the nerve root. There is a chance that even though we don't poke through the nerve root, that the nerve can still be compromised or damaged. Shot? And there's this situation, it's quite interesting, where a nerve can split right there in the foramen into two. And there'll literally be kind of a crotch between the two nerve fibers like that. And if you get your tube right between those two nerves, the patient can actually have a stretch injury to the nerve where they wake up and they have some weakness or numbness, and you didn't necessarily damage the nerve, you just did what's called a neuropraxic injury. And neuropraxic injuries to the nerve typically heal, they just take time. I can feel a giant tear right now. So this tear that you saw with the dye is not representative of how big the tear really is. I can feel the dilator going in quite easily, meaning the tear is huge. So it's a partially healed tear. Shot? So the disc has been trying to heal, but unsuccessful. You can see the dilator is pushed back. You know why? You know why the dilator is pushed back? Because there's so much pressure in this disc. Look at this, guys. Henry, can you see this? There's so
Yes.
much pressure in this disc. It's literally pushing the metal back. All right, so that's pressure comes from inflammation. It's like a piston. All right, let's get that back on. Mm-hmm. Tell me when you're ready. Yes? Shot? Yeah, you're not in. You gotta torque it. No, you gotta torque it a little.
You just have my glove. I don't want to let him there.
Shot? Yeah. Perfect. That should be it. All right. So what you're going to see when we get in there is basically the blue stuff's going to be wanting to erupt out of here. Think about all that pressure on that painful disc this poor person has been dealing with for a long time. We're going to fix that today. We're going to take her back pain away. I'm really excited for her. I don't know if I told you, but she's actually a nurse. And nurses have a special place in my heart. Nurses got me through residency. Yeah, you too, huh? They saved my butt. How many times? Those are the nurses at Shands Hospital in Gainesville.
Trauma nurses at University of Miami.
There you go. All right. There is your part of your herniation. And it's looking like it just wants to burst out of here. Let's go laser. I need the light off up here.
Not ready. No, it's not.
Don't turn the laser on just yet. All right, I'll use this for a minute while you're doing that. All right, so let's show our audience, Henry, why do people get back pain from a herniated disc? What is it about a herniated disc that is so painful anyway?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right. Welcome back. We are currently doing what you saw, actually you're going to see in the next video, which is called an annular debridement, where we're cleaning up the tear in the back of the disc that's causing all the pain. And that's a unique procedure to the Deuk laser disc repair. I understand we have some questions from our audience. Let's go ahead and get those questions answered.
Yes, these first two questions come from Rigaleb on YouTube. And they asked, the first question, have you ever operated on people with hypermobility spectrum disorder or Ehlers-Danlos syndrome, aka very loose ligaments? Do you have experience with this set of patients?
Okay, great question. So thank you for asking. Do I have any experience operating on patients with the hypermobility syndromes like Ehlers-Danlos? The answer is yes, I have operated on them. Not often, and it's not common, but they do get disc problems as well. And I've operated on those types of patients over the years. But again, it's not any more common or often than, you know, the normal population with respect to the discs. Now, I don't screen for Ehlers-Danlos syndrome in my patients, so I could actually have patients that come in with Ehlers-Danlos that I don't even know, or Marfan syndrome would be another one, and I don't even know that they have it because I'm not checking their, you know, their palate or their, you know, whether or not they have that condition, which is usually done through, I think, genetic testing. So we have no problem operating on that population if that's what you're asking, if it's necessary. All right, look at the inflammation right there. You see that little bundle of red inflammatory tissue? Once again, we are at the L4-5 disc, correct, Luis?
Yes.
Yeah. We're going to start with that one, this case. Normally we start at L5-S1, but we decided to do L4-5. What I'm seeing here is kind of a mixed age disc herniation, and there are elements that could be a couple of years old, and there are some elements that are going to be older. People always want to know, when did my herniation occur? And the answer might surprise you. Herniations typically occur over time because it's a multiple event. It's not one event in time. Most herniations happen over time through multiple herniations. You can see how swollen this disc is. This tissue right here is very edematous, full of water. I can tell just by its consistency and the way it looks. The fibers are very swollen. When we came into this disc with the dilator, you can actually see the crisscross fibers of the annulus. And what you're seeing between them is the blue stuff is herniated disc. And that's what I'm trying to remove. I'm trying to debride this annular tear. All right, it's a relatively newer looking tear. What other questions do we have from our audience, Henry?
Yes, we have a second question from Rigaleb on YouTube, along with a few other questions from other people on YouTube. The second question from Rigaleb is: Have people that you've treated tried hyperbaric oxygen therapy for recovery? And if yes, did it sped up the healing?
Great question. So, first of all, this is a big part of the tear that we're here to debride. I just want to bring your attention. And if you rewind a few seconds, you'll see how much pink tissue there was. The pink stuff is the granulation tissue, and that's where all the pain is coming from. So the question was, have I ever used hyperbaric oxygen to help people heal from this condition? The answer is no, I've never prescribed it for after surgery to help their disc heal. Could it potentially help the disc heal faster? I think it possibly could. I just don't know whether it would. I know that hyperbaric oxygen increases the oxygen tension in wounds, but typically those are, I don't know the exact mechanism, but I think those are kind of open wounds that are open to the air. These discs are not open to air because they're down inside your body. So I'm not sure if the hyperbaric oxygen would have the same effect that, say, an open diabetic sore would, you know, a non-healing ulcer would in the skin. But it's a great question. I just don't know enough about it.
We have a couple more questions.
Yeah, here's the tear right there, and look at all that pink stuff on it. That's where all the pain's coming from. But go ahead, keep asking questions.
This next question comes from Jensen Gomez, or Jensen, excuse me if I mispronounce that, but from Jensen Gomez on YouTube. They asked, I have seen many of your videos, and you always recommend laser surgery, but when would you recommend fusion? I've had 2 discectomies now and have a fusion scheduled for the future.
Yeah, great question. Yes, if you notice, not only do I recommend laser surgery all the time, but I'm doing laser surgery all the time. There's a reason, is that we don't need to do fusions really anymore. It's very rare that we would need to do a fusion. A fusion would only be needed if it's really unstable spine. And what I mean by that would be gross movement between the bones at the joints that's severely painful or entrapping the nerves. And 99% of people I treat don't have that. They just have a painful disc that can be fixed. I'm sure your problem could be fixed with the laser as well. I don't think you're going to need a fusion. There's no reason for you to have a fusion done unless you couldn't come here and get the laser done. I would recommend the laser surgery over fusion any day. The laser surgery replaces fusion. The laser surgery replaces artificial discs. The laser surgery replaces microdiscectomy. The laser surgery replaces laminectomy. The laser surgery replaces pretty much all spine surgery, except for a few cases where the instability is so bad that the patient requires a fusion, like for example, a trauma where they have a fracture dislocation. All right, we're pretty much done here. You can see the tear. I've debrided it. The rest of it looks good. I don't see any other issues. Maybe just right here, and then we'll be done. But we actually had 4 surgeries today, and next week we've got 9 surgeries. We're going to do 4 on Tuesday, 4 on Thursday, and 1 on Wednesday. A quickie Wednesday morning for my clinic. Laser, 2-level, lumbar. You know we have 4 cervicals on Tuesday, I think? So the laser surgery is a far better surgery than fusion or microdiscectomy or artificial disc. It's the future of spine surgery. I keep saying it. You know, a lot of people don't know much about me and my training, but I was trained at the top neurosurgery program in the country back in the 90s and early 2000. And fusion was becoming very popular there. We were some of the pioneers in that technology, and artificial discs as well. And the university I trained at was a top spine program. And I'm telling you, there was no endoscopic surgery being done. It was all open fusion surgery, and artificial disc. I got a lot of experience doing those types of surgeries for many years, and I've done, you know, my own career since then. I've done 1,000 lower back fusions and 1,000 anterior cervical fusions and another 500 PCDF. So a lot of fusion experience, but I'm telling you, it's completely unnecessary 98% of the time. This is a far less invasive alternative to fusion, and it's much safer for the patients. That's why, by the way, this is a nurse, but we get doctors, we get nurses, we get a lot of healthcare professionals that come here for the laser surgery because they don't want fusions or artificial discs. They know how dangerous those surgeries are. And they see how the patients do after those kind of fusion surgeries. They don't want the same for themselves. All right, you can see on the x-ray we've just finished L4-5. We're now going to start the L5-S1. The guide wire is at the front of the L5-S1 disc. Shot? Uh-huh. Shot? You don't think it's still effective in there? We use Marcaine.
Yeah,
It was just 10 minutes ago. Shot? Shot? I'll give some more. But not on the skin, right? You mean talking about in the disc? Yeah. Skin? But the cut's already there. We already cut it. We already made the cut. Shot? All right. So we're heading down to the L5-S1 disc. Shot? I'm going to need you to put a little pressure while I aim down. Now it's interesting, her L5-S1 disc is angled kind of up towards her head at the back. So that means our starting point, our entry point, has to be closer to her shoulders. And that's pretty typical for anybody with an L5-S1 disc that's oriented that way. All right, right at the back of the disc, I can feel it. I'm going to go through the tear now. Shot? Give me a second. Shot? Yep. Beautiful. All right. So, any questions from our audience, Henry?
Yes, we have a question from Teak on YouTube,
Hi, Teak.
and they asked two questions. Well, three. The first being, does the tear show on camera when you enter the space, or just the disc? Also, can thoracic and lumbar be done during one surgery?
Yeah, so first of all, the tear is visible as we back out of it, and thoracic and lumbar can be done at the same time. We've done it before. Great question.
They have another question
Sure.
from Teak. They asked, and how far out are you scheduled? Are there openings in January?
There are openings in January if that's what you want. You just need to, if you're interested in this surgery, folks, you're welcome to send us your MRI. And you do that through our website. We have a mri.deukspine.com. Why don't you post that link? And you or somebody that's suffering with neck or back pain, you get a free MRI review, folks. It doesn't cost you a thing. All you got to do is upload your images. I will look at your films. I'll talk to you and do an examination virtually with Zoom. And if I can figure out where your pain's coming from through that interview, and if it's coming from a disc, and we can fix it, we'll offer that procedure to you. It's an opportunity to get questions asked, or answered, I should say. You can ask questions, and I'll give you my answers. We can talk about anything you want to talk about. If you want to talk about fusions, talk about fusion. We can talk about artificial disc. Basically, you get 10 to 15 minutes of my time for free, and I do that for everybody. Doesn't matter your situation, and it's free. And that way it's my ability to kind of educate people one-on-one for their specific problem, you know, and address any concerns you might have. So I encourage you to use the free MRI review service that we offer at Deuk Spine. It's a spine MRI that we review, by the way, not any other body part, just necks, backs, basically lumbar spine, cervical spine, thoracic spine. We don't do brains or other body parts yet. There was a time when I was trying to build a minimally invasive laser brain surgery, but the problem is I just don't have enough time. There is now laser surgery for brain tumors and lesions in the brain, and being a brain surgeon, I'm able to treat those things, and I wanted to build an outpatient center to treat those lesions. But unfortunately, I'm so busy with my spines that I haven't had time for the brain stuff. But I think it's definitely worthwhile. You know, there's a lot of brain surgery being done in hospitals unnecessarily when it could be done outpatient in a very safe outpatient environment. Maybe in my next life. Yeah. How old? Well, I think this disc here, the L5-S1, it looks more older. There's some calcification. It could be over 10 years. I think the L4-5 looked newer, probably within a few years, maybe up to 5 years.
We have another question.
Yes,
This comes from Teak once more on YouTube.
ITEEK.
And they asked, how long until the other doctors that assist you will be able to perform these?
That's a great question. You mean perform them independently, I assume is what you're asking.
I believe so, yes.
Yeah. I don't know. It's a great question. I think Luis could do these surgeries probably with some additional guidance soon. You know, it's a great question. I don't have an answer for you. Haven't really thought about it, and I don't want to just say something and then, you know, not be able to stand behind it. So, just as a general, let's just talk generally. Let's say there's a surgeon who comes to me and they want to learn how to do this surgery. And I'm training them, and let's assume for a moment they already have completed their residency in, say, neurosurgery or orthopedic surgery. So if it's a neurosurgeon, they've done 7 years of training in neurosurgery, they've done spine surgery, and let's assume for one moment that also that they're really good at what they do, okay? They're conscientious, they're motivated to do really good, they're hardworking, intelligent, open-minded, and they want to do a good job. So that kind of a surgeon can pick it up pretty quick. Probably 6 months if you're talking about a top surgeon, top neurosurgeon. On the other hand, if it's an orthopedic surgeon who has not done a spine fellowship, that means they're not really doing much spine during their training. See, orthopedic surgeons do 5 years usually worth of residency, but they don't do spine surgery in those 5 years. They do hips and knees and shoulders and other types of orthopedic procedures. By the way, here's the tear somebody was asking about before with the blue stuff, the herniation in it. So an orthopedic surgeon with 0 spine experience is going to take 2 years minimum to learn how to do these surgeries properly and safely. But let's say that they've already completed their spine fellowship before they came here. I think a year of training will probably be suffice it. You know, again, that's top caliber surgeons, not just your run-of-the-mill surgeons. They have to be top of the game. This is not an easy surgery to do. I know I make it look easy, and the reality is that any kind of surgery can have complications, and you've got to be prepared to manage those complications. And managing complications means, first of all, identifying that there's a complication, recognizing there's a complication, and then acting on it and doing what's right for the patient. And a lot of doctors aren't prepared to do that. They don't know how to recognize certain complications, and they don't know how to manage certain complications, which is why, you know, there are many doctors that shouldn't be doing these kinds of procedures because they're not trained to manage problems related to the procedure. You know? For example, if this patient were to have a heart problem, I would not be expected to manage a heart problem as a neurosurgeon, but I would be expected to, with the help of the anesthesiologist, recognize there's a heart problem and then to get them the right medical care, stabilize them to the best of our ability, and then get them into a heart doctor. Come on, man.
You ready?
Let me know when you're ready. I gotta stop talking. I think I'm putting Oscar to sleep. All right, what's the next question?
Next question comes from Justice on YouTube.
Uh-huh.
And they ask, after taking out all of that disc material, do you put more material back in there when you're done? And what type of material do you use, if so?
Yeah. Hey, Justice, great question. So guess what? This is not taking out any disc material. The disc material that we're taking out right here was already taken out. The body took it out. Basically, when you get a herniated disc, you get a tear in the wall, and then this stuff here I'm removing pushes through the tear, and that's what we're seeing. So it's already out of place. It shouldn't be here. It's already herniated, and all I'm doing is removing it from where it shouldn't be. Okay? So it's kind of like if you run a daycare center and all the kids are supposed to be inside the lunch hall eating, and somebody runs outside and goes somewhere they're not supposed to go, they're out of place. Then you go get them and put them back where they belong. Except here we don't put people back where they belong, where we don't put the disc back in the middle, because once it comes out like it has, it's damaged, and it's permanently damaged. There's a big one. It's permanently gone. I mean, you can't put it back. So we're not removing disc material. We're just cleaning up the stuff that's spilled out, so to speak. You don't need this stuff. It's in the middle of your disc because it was part of your embryological development. But the reality is that nucleus pulposus is no longer needed in an adult. And the reason it's in the middle of your disc is to hide it from your circulatory system, because it's so inflammatory. It's so irritating to nerves that it needs to be packaged away. We talked about this in other surgeries, this concept of your body just packages it into the middle of your disc so it just doesn't cause pain and inflammation. So really what's happening here is this herniated disc is just causing pain through inflammation because it's out of place, and it doesn't get along well with this area right here. Causes inflammation here, and that inflammation is what people feel as pain, back pain. So just to reiterate, the stuff I'm removing is not removing normal disc. I'm removing disc that's already out of place. Shouldn't be here. I'm just getting rid of it with the laser and the grabber. And then you don't need to replace this stuff because it serves no real purpose in the adult. It just is, it's tucked away and hidden in the middle of the disc until you injure your disc with trauma, and then it escapes. And once it escapes, it causes lots of pain and suffering on its way out. I don't know if that makes sense, but let's go ahead and show the video of why do herniated discs cause pain. And keep an eye on the annular tear in this video, and keep an eye on the herniation, the nuclear material in the video, and you'll understand why these herniated discs cause so much pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. So after watching that video again, hopefully you're able to see why people get pain from their herniated disc, but also how the herniation isn't really something that, I need a laser, that you can put back. It's once it's out for good. There's no putting the, what do they say? No putting the cat something back in. The what?
The cat can't put the cat back in the bag.
Can't put the cat back in the bag.
Or back in the tub.
Yeah. So what's done is done. Stand by. There we go. Hold it. Almost done. Just want to get these last few pieces of herniation out. That was a good one. I think that's it. I don't really see any more. Let's go a little more laser. Sorry. I just want to make sure I got it all. This is really old stuff. Can tell. Is that right? Yeah, it matches up. It matches up with a car accident at that age. Yep, yep, absolutely. All right, Henry, any more questions from our audience?
Yes, a couple.
Let's have them.
All right, the first one comes from Rigaleb on YouTube, and they asked, do you operate if the MRI only shows up a small tear with no sign of herniation, even though there is pain? And if not, can the patient avoid progressing to a herniation?
Yeah, Rigaland, yes, if there's a tear, there's probably a herniation. You cannot see a tear on an MRI unless there is a herniation. So if you're getting a read from your radiologist that says tear, then there is a herniation there. And that herniation is the cause of your pain. It's really simple though. I can tell you by looking at your MRI with my own eyes, and I'll do that for free. So you don't have to guess as to whether or not your your tear is real or causing your pain. Just fill out the free MRI review form. That's it. And I'll give you my opinion. Okay? It's mri.deukspine.com. So basically, there's 5 types of tears of the annulus, grade 1, 2, 3, 4, 5. Grade 1 is a small tear on the inner wall, and it doesn't go to the outer half of the annulus. Those are not painful ever, and they're not seen on the MRI. MRI cannot detect those. Then there's grade 2 tears, which basically is pretty much a full thickness tear into the painful part, outer part of the annulus. And grade 3 is when you have a herniation inside that tear that goes all the way to the periphery or outer wall of the disc. So a full thickness tear with a full thickness herniation. And it's really kind of a disc bulge, but it's still a herniated disc, and they can be very painful. And then grade 4 is when you have a full thickness tear with the herniation in the tear and some of it sticking out into the epidural space or the foramen. And then grade 5 is an extruded fragment through the tear, completely out into the spinal area around the nerves. Very rare is there a grade 5 tear. The most common we see that are causing pain are grade 3 and grade 4. Grade 2s could potentially cause pain, but a grade 1 never does. So MRIs can only detect really grade 2s, 3s, 4s, and 5s, never grade 1. So if you're having pain and your MRI sees an annular tear, it's probably a grade 3, which definitely could be painful. Best thing to do is to have me look at it and figure out if that's what's causing your pain. And then repair it with this particular surgery. Okay, let's show our audience before I take any more questions, the incision. There it is, right there. You guys see this, 7 millimeters?
Yep.
We're gonna put one little stitch, and then we're going to put a steri-strip. The stitch is underneath the skin, so it's resorbable. It dissolves on its own. You don't have to come in and get it removed. Our patients usually end up flying home the next day after their surgery. Today we had a patient from Boston, a patient from Alabama, and a patient from Missouri. Near Kansas City. Oh, we had one from Arizona. Oh yeah, the first patient, which we didn't broadcast, the Deuk plasma rhizotomy for facet pain, was from Arizona. So we had an Arizona, a Missouri, a Boston, and an Alabama. Last week, all of our patients were from Florida. All right, go ahead and type your questions. I'll answer them for you. I'll be there in about 5 to 10 minutes. Meantime, let's show our audience another video that's educational.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
I'm Dr. R. Deuk Machen here at the Deuk Spine Institute with one of my patients who's traveled from North Carolina because he had some herniated discs in his lower back and he was having problems with the back. What kind of problems brought you to Deuk Spine Institute?
Dr. Deuk, it was severe pain that I had never experienced before, and pain that scared me so much that I thought it was going to change the way I lived. I've got a family and I'm active, and it literally scared me to death. And as I'm talking to you right now, the hair standing up on my neck, the pain that I was suffering and where I thought I was, I didn't think there was going to be an answer.
And you were pretty much bedridden. You couldn't get out of bed. I remember you showed up here in a wheelchair because any standing was causing sciatic type pain in your leg.
Yeah, there was no doubt. And that's not an over exaggeration where I could maybe get up, like stand for 15, 20 seconds so I could get to the bathroom to go urinate, for instance. But then when I got there, I had to lay on the floor so I could rest up a little bit so I could stand with pain to even be able to try to urinate. And this went on for 2.5 weeks. It was absolutely brutal. And there was no respite. Pain that I had in the past, I could find some position where there was some respite from the pain, and there was nothing.
So your wife is a physician. Was she able to fix your back problem for you?
I wish. No, I mean, she consoled me. And in the town that we come from, we know a lot of folks. And to be absolutely honest, we just weren't getting a lot of help. And like I said, we know a lot of folks, and it was prolonged, and we were talking about pain management and all that, and that's just not for me. And like I said, I was scared to death.
The problem with pain management, unfortunately, is that it doesn't fix the issue when you have a herniated disc and back pain from a herniated disc, because you need surgery on that disc to repair it. That's what the Deuk laser disc repair did. And you can actually see here that we went into his disc with the endoscope and we were cleaning out the herniation with the laser. And the laser actually makes a huge difference. People say, oh, lasers, they're not used in spine surgery, but they are. And they're very, very powerful tools and very precise. So we were able to clean out your discs, remove the herniation. And how do you feel today?
I feel great. I mean, it's probably, I mean, I know I'm on camera right here, but I literally could not walk into the office yesterday. And I'll just, I mean, you're gonna see my shorts and everything, you'll have to edit, whatever, but I'm able to walk.
That's awesome.
And I'm just, it wasn't even close. I was actually, and I don't know if you can tell from the camera that what my personality is, but I try to be very polite, and I was apologizing for profusely sweating because I hurt so bad. It's not because of the Florida heat by any means. It's because I hurt so bad. I never experienced pain like that. And like I said, there's no
because you're a redneck too. You know, you're not that far from Florida.
That's
you're
right.
Just up a state or two, right?
That's right. Yeah.
A couple of states. So you're feeling better today. It's been less than 24 hours since we did your surgery. You went home an hour after the surgery, back to your hotel with your lovely family who I met. And how do they feel about your progress?
They're happy that I'm happy. You know what I mean? Because they were scared too. You know, now they were putting on a strong front, but I am just telling you, I was at my wit's end. And I certainly are a lot more appreciative of people who have pain that I'm aware of, because when there's no rest from it, oh my gosh, you know what I mean? I was really at my wit's end, and you saved me. So I appreciate you very much.
You are welcome, sir.
Yeah.
Is there anything else you want to say to your fans out there?
Thank you. Sorry, I could have prettied you up for you a little bit better. So just had surgery yesterday.
All right.
Cut me some slack.
Excellent. And you're heading back home today, correct?
Yeah, right, going back on the plane later this evening. The kids are going to swim a little bit down here in Melbourne. I am just going to rest and watch TV, but then we're going to get on the plane a little bit.
Awesome.
Yeah.
All right. Well, congratulations. You had faith.
Yes.
Took the
I have
leap
faith.
and you got the surgery done.
Yes, sir.
All right. Awesome. And hopefully you enjoyed watching our surgery. This is the final surgery of the day. And our patient came to us from Alabama. She is a nurse. She has pain in her lower back, and she's had it for many years. She's had an accident where she had a car accident, I think, and she injured her back. Anyway, her pain was this area. When I looked at her MRI, I noticed immediately she had a herniated disc, degenerated disc at L5-S1. Both of them are fixable with the laser. And then she had another herniation at L4-5, not as bad, but once we got in there, we saw that it was a very swollen disc, and it was literally so much swelling, it was pushing my metal dilator out of the tube. It was pretty interesting. But that said, we got both discs fixed nicely. Hopefully she's going to do well, and she'll probably be here for about an hour waking up, recovering, and then she's got a friend who's going to take her to the hotel. We always see our patients the next morning, usually 12 hours after their surgery. They come in for a quick checkup, make sure they're doing all right, go over the instructions with them on the restrictions of their activities to make sure they don't re-injure their disc. We also go over their diet, exercise regimen, and use of any kind of DME products like back braces or neck braces. That typically happens the day after surgery. All right, so let's see what kind of questions we have.
Our first question comes from Justice, and he asks, what is the recovery time?
Yeah, Justice, thanks for asking. The recovery time for this endoscopic surgery is typically 1 hour, and then the patients can be discharged home. Many of our patients travel from out of state or out of country, so they end up in the hotel where they spend the night, and then they come back in the morning for a quick checkup, and then they can go home. Most people travel home the next day after surgery. The recovery time is literally 1 hour. Many of our patients go back to work the next day. Next question.
Next question is from John Doe on YouTube.
John Doe.
I love it.
All right, John, welcome.
And he asked, Doctor, do you have offices in Austin, Texas?
All right. Just having a little Halloween pretzels. No, we don't have an office in Texas, unfortunately. We're not a big organization, to be quite honest with you. We're basically the old term mom and pop shop. My wife and I started this Deuk Spine Institute 18 years ago, and we now have grown to about 70 employees with really one location. The Titusville location is just a satellite office, but we're located here in one little building, 20,000 square feet. We're doing all this broadcasting and surgery from one facility. But we are in Melbourne, Florida, which is the Space Coast. It's right near NASA and SpaceX. You'd fly into Orlando, and you travel about 45 minutes to our office by car.
I don't believe we have any further questions, but we do have a couple comments, one from Teak and then another one from John Doe. The first one being from Teak, saying, after following what the Deuk Spine Institute does for a long time now, I get so irritated when my doctors say there's nothing that can't be done for them. And like, here are more pills, pretty much. That's what they
Yeah, Teak, I feel for you. I really do. I'm sorry you're going through that. You and millions of people around the world, which is why we do these broadcasts, to try to spread the word that there is definitely a better way than pills and living in pain and being miserable the rest of your life. And we discovered that cause of back pain right here at Deuk Spine Institute, and we've been fixing it now for 16 years, actually longer, 18 years, if you include the fusion surgeries that I've done. But if you're able to get to Deuk Spine someday, I'd love to meet you in person and be able to fix your back.
Awesome. And the last comment we have is from John Doe. He said, I've been watching for the last week. Something is causing issues for me at L4 or L5. Chiropractor says it's bulging or herniation.
Yeah, sure. So John Doe, thanks for reaching out. You're having pain at L4-5 in your lower back. That's kind of where the belt line is. And you have a chiropractor who's told you you've got a bulging or herniated L4-5. You know, just so you all understand, a bulging and a herniated disc are the same thing. There's about 10 different terms for it, and they're all the same thing. It's basically a tear in the wall that lets the jelly in the center push through the tear and get stuck in the tear. And we call that a bulging disc, herniated disc, protruded disc, extruded disc, ruptured disc, slip disc, extruded disc, degenerated disc. So they're all referring to the same condition. It's basically the tear and the herniation. And over time, the disc will start to darken in color on an MRI T2 weighted image because it's losing the water content. So when it loses water, the radiologist will call it a desiccated disc or dehydrated disc. And the disc will also start to collapse, and you can get changes in the end plates called modic changes. But basically it's all part of a continuum of degeneration of that disc over time. It all starts with the annular tear and then the herniation, just like you saw in our video. All I can tell you, John Doe, is that we're happy to fix you here at Deuk Spine if you want to come here and get fixed. Submit your MRI if you'd like ahead of time, and we can do a virtual call with Zoom, and I could talk to you and answer your questions. Make sure you're a good candidate for the laser surgery. Anybody out there that knows somebody with neck pain or back pain, send them to Deuk Spine. We'll first of all figure out where it's coming from, and then we'll be able to fix it for you. About 20% of the patients, 1 in 5, have more than one cause. We'll fix your disc, but you might have facet pain or sacroiliac joint pain or piriformis pain as well. That will need to be addressed as well. That said, I think we had one comment from a workman's comp person, and we do accept work comp insurance. Just understand, just because we accept work comp insurance doesn't mean they're going to pay. So you really need to work with your work comp carrier or your lawyer to get the work comp carrier to pay for your treatment at Deuk Spine. But we accept work comp just like we accept all commercial insurances. And whether they pay or not, that's the real question. And we don't know whether they're going to pay or not until later on. So we have a work comp office and a work comp division. And right now, Elizabeth and Richard are working there over there. But you can reach us on our work comp line at 321-775-8010. 321-775-8010, or get a free MRI review and see if you're a candidate for us to fix your back or neck. Hope you enjoyed the surgery. I don't think we have any more questions. I'll leave you today, and we'll be back next Tuesday.